Hello there, welcoming you all to the second part of the nursing management of stroke. This is me, your host Dr. Abhishek Tamrakar. In this part, we'll be discussing on what a professional nurse should do when they encounter a stroke patient. We'll be discussing on the tissue plasminogen activator medicine, its doses and indication and contraindication, the ways of management of blood pressure in stroke patient. With all this information, we'll conclude this part. So let's move forward. Whenever a nurse encounters a patient with suspected stroke, first of all, we have to identify the signs and symptoms of possible stroke. That would be our fast mnemonic. We have to go on with our fast mnemonic and see whether we have any signs of strokes or not. Then we have to activate the emergency response. After that, we have to start on clinical EMS assessment and actions. We have to look for the airway, breathing and circulation. We have to provide oxygen if needed, perform pre-hospital stroke assessment. We have to establish the time of symptoms of onset. We have to triage it according to the stroke center. We have to alert the hospital wherever you are going to take the patient to, and the hospital staff will have adequate amount of time for their preparations as soon as they land up in your ER. If possible, we have to check the blood glucose level, because some of the time the stroke patient and the patient with hypoglycemia, they act in a similar manner. So for that reason, we have to evaluate whether the patient is hypoglycemic or a stroke patient. On arrival to the emergency department, there are few things that we have to complete within the 10 minutes of the arrival. We have to assess for the airway, breathing and circulation, all the vital signs. We have to provide oxygen if the patient is hypoxemic. We have to obtain IV access and perform laboratory assessment. My recommendation for the stroke patient is to open two large bore cannulas in the cubital vein. We have to check the blood glucose, treat if indicated, perform neurological screening assessment. It should be quick. We must remember that time is brain. We have to activate the stroke team, because in every hospital there is a stroke team and it should be informed as early as possible. In my view, if you get a call from someone outside, we have to inform the team leader as soon as possible so that he can manage each and everything at the time. We have to order an emergency CT scan or MRI of a brain according to the available facility in your hospital. We have to obtain an 12-lead ECG. After the 10 minutes has passed, we must have all these informations on our hand. Then we can immediate neurological assessment by a stroke team or the resident. Review of the patient history, establish time of the symptoms onset and last known normal, perform neurological examination. An NIH stroke scales or Canadian neurological scale should be done within the first 25 minutes of the arrival to the emergency. Now by the time of all the examinations, we will definitely have our CT scan film with us. We have to judge whether it's a non-hemorrhagic stroke or a hemorrhagic stroke. If it is a hemorrhagic stroke, then we have to consult the neurologist or the neurosurgeon and consider transfer if not available. For a stroke of more than 35 ml of bleed, we have to operate. If not, we manage them under the conservative management in the stroke unit. But what if there is a non-hemorrhagic stroke? This is the thing that I'll be discussing more on this topic. If there is a non-hemorrhagic stroke, then probably it should be an acute ischemic stroke. We have to consider the fibrinolytic therapy, but for this we have to consider whether the patient falls under the exclusion criteria or the inclusion criteria of the fibrinolytic therapy. We have to repeat the neurological examination after deficit rapidly improving to normal. If the patient is a candidate of fibrinolytic therapy, then we have to start on with the rtpa, and if the patient is not a candidate, then we can administer aspirin and the 12 anticoagulants and admit it under the stroke unit. But if the patient is a candidate of fibrinolytic therapy, we have to start on tissue plasminogen activator, but we have to reconsider the patient whether he falls under the inclusion criteria or the exclusion criteria, whether we can give him the TPA medications or not, because there are lots and lots of complications that will arise after the administration of TPA. What is the most important risk complication is rise in BP and neurological deterioration. So, under good supervision, we have to start on rtpa. Now, in next slide, I'll be telling about the rtpa doses. rtpa stands for tissue plasminogen activator. The doses for tissue plasminogen activator in a stroke patient would be 0.9 mg per kg IV, with 10% of the dose given bolus over 1 minute and rest over infusion lasting for 1 hour. The maximum of the dose is 90 mg can be given. There are few exclusion criteria for tissue plasminogen activator. They are intracranial hemorrhage from CT scan, clinical presentation suggestive of subarachnoid hemorrhage, even normal CT scan, evidence of infarction more than 1/3 of the cerebral hemisphere, that would be considered as a huge infarction, which could not be fibrinolyzed by a tissue plasminogen activator. It may result to excessive bleed. History of intracranial hemorrhage. Uncontrolled hypertension based on repeated measurements of more than 185 mg per TL on the systolic and 110 mg per TL on the diastolic, because I have already explained that one of the major complications of tissue plasminogen activator is hypertension, and if the patient is already under hypertensive medications or already has the uncontrolled hypertension, then it would be very, very difficult for you to manage their hypertension. And another exclusion criteria is witnessed stroke seizures at the stroke onset. If there is a seizure during the stroke period, then we have to exclude the patient for the fibrinolytic therapy. If these exclusion criteria are not met, then we can transfuse the tissue plasminogen activator according to the doses that I have earlier explained. So keep in mind that the dosage is 0.9 mg per kg IV with 10% of the dose given bolus over 1 minute and rest over infusion lasting for 1 hour. The maximum of the dose is 90 mg per kg, irrespective of the weight of the patient. Since I have been saying that the patient may have increased blood pressure, depending on that, we can manage the patient on patient not using the fibrinolytic therapy and patient using the fibrinolytic therapy. The management of blood pressure differs by them. If the patient is not using the fibrinolytic therapy, if systolic blood pressure is less than 220 and diastolic blood pressure is less than 120, treat the patients or the symptoms of stroke like headache, pain and nausea, etc. If the systolic blood pressure is more than 220 and diastolic blood pressure is more than 120, the main medication that you are going to give to the patient is the labetalol, which is the best medications to decrease the blood pressure in emergency situation. A labetalol of about 10 to 20 mg IV for 1 to 2 minutes. We can repeat the dose every 10 minutes and maximum dose is about 300 mg. But What if the patient is under fibrinolytic therapy? We have to monitor the blood pressure every 15 to 20 minutes for 2 hours, then every 30 minutes for 6 hours, and finally every hour for 16 hours. If the blood pressure is still high, then we have to start on medications like if the blood pressure is more than 230 and diastolic blood pressure is less than 140, the labetalol can be given. Labetalol of 10 mg IV for 1 to 2 minutes. This dose can be repeated or doubled every 10 minutes and the maximum dosage is about 300 mg per 300 mg. In this way, we can manage the hypertensive patient even if we have used the fibrinolytic therapy or the patient has not been given any fibrinolytic therapy. We must understand that acute management of stroke is necessary and time is bring, and the nursing staff must be efficient enough to manage stroke whenever it lands up into your ER. First, thank you for their patience. Please like and subscribe to the YouTube channel for more videos. Please like and follow the Facebook page and Instagram in description below for the slides and more medical updates. Free digital OPD is available by the Facebook page. Thank you.